Okay, well, welcome everybody. I'm really excited to be joining you. I wish that I was there in person. I know how delightful Madison is this time of year. It'd be wonderful to be just sitting on the lake and having a beer on the terrace or something. So in lieu of that, it's been a great virtual visit, everything considered. I know that you've been having a really busy week on campus and some pretty big events kind of transitioning this week. So thank you for joining, and I look forward to your comments. So today I'm going to be talking about the effect of in utero exposure to the 1918 pandemic on child mortality in the United States. Before I go any further, I would be remiss if I didn't acknowledge my wonderful team. I've been working with scholars really across the country. Jonas Halgertz at the University of Minnesota, as well as Rob Warren. I have a great graduate student, Elizabeth Anderson, here at Indiana University. And then also we've had expertise from Florencia Torche, who has done work in this area, and Claire Margerson, who is our kind of resident epidemiologist on the team. So we are fantastically lucky to have such an expert and excellent team at our disposal. So before I kind of go any further, if I were there, if I were having an opportunity to speak with you, I could introduce myself in a little bit greater detail. I'm a medical sociologist with training in public health administration and policy, and also health demography. And broadly, I study the structural and social factors such as social ties that shape health and mortality over the life course. So just to give you an example, I kind of have an uncanny ability of entering the field. Apparently, when we are having pandemics about 10 years ago during the 2009 and 2010 pandemic, I was in the field collecting data. And what resulted is this project, and this I was working on with a couple of co-authors. We were looking specifically at the role of social networks and educational attainment on vaccination decisions among women who were pregnant individuals, I should say. And when we think about this, what really kind of stood out to me is that our networks are structured by, if we think about the way the people that we talk to by educational attainment, and they're going to differ, they're going to be stratified. But when it comes down to some of these vaccination decisions, it was often the people that you were talking to, so social ties that were as important or more important in the way that people were making decisions. And obviously this holds a lot of implications for the way that people are going to be making decisions about vaccinating during the current pandemic. So from this, and in a lot of my other work, I've actually used pregnancy as an empirical example. In this particular case, it was ideal because I was wanting to understand how people were making decisions when they were encountering information for the first time. So I was using, in this particular study, prima gravida women who were pregnant for the very first time. A little bit more complicated to be doing the research, but an excellent way to kind of isolate some of these social processes. And then I became interested now in the project that I'm going to be presenting today in what is happening during the prenatal period? What is happening, and how does this contribute both to inequities and some of the differences that we see over the life course in terms of health and mortality? So if we're thinking about the life course, we know, and I don't need to tell any of you this, so much of this is actually from your department, we know that we have to think about the entire life course perspective. If we want to understand how people age, if we want to understand some of these specific physiological processes, weathering, for example. But we also have given a great deal of attention to specific critical periods or specific sensitive periods. And here we've given a great deal of attention to childhood in particular. We know that what happens in early childhood can set people on a specific trajectory over their entire life course. And so this is a very important, sensitive or critical period over the life course. But what is happening during the prenatal period and even during that preconception period is also important. And so this is what I'm going to be focusing on today. This is building on really observations for centuries that if something occurs in utero, we observe changes in the health of that individual and over the entire life course. But more specifically, work by Barker on the fetal origins hypothesis, which in 2007 was renamed the Developmental Origins of Health and Disease. And this was renamed in order to really account for the fact that these developmental processes are represent a broader physiological or biological mechanism that we need to understand, and that we really need to bring people from different disciplines together to understand. So our question for today is relatively straightforward. Did in utero exposure to the 1918 influenza pandemic affect child mortality? So once again, this paper, we were working on this prior to the current pandemic, but kind of found ourselves studying a topic that was pretty relevant for today. So if we're thinking about the in utero exposure to the 1918 pandemic, I'll just return to our figure that we have here. And when we look at this, we can, here I've added the prenatal period here. We want to understand what's happening during gestation. And we're thinking specifically about the 1918 influenza pandemic. We know that this has been tied to higher rates of morbidity, a shorter lifespan, to physical disability, and specifically cardiovascular problems and metabolic disorders. And I'll explain some of the physiological processes and reasons why those in particular are what we are observing later in life. But then overall poor self-rated health, which is just, as we all know, a global measure of overall health in the life course. But if we look at this over the life course, we highlighted the period of gestation, and we know what's happening later in the life course, but we're missing something here. We have this missing link. And this is what we address in this particular paper. What's happening in childhood? Now, if we identify specific mechanisms or specific biological processes that could be occurring, we focus on three. The first is increased stress, undernutrition, and infection. I'm going to walk through each of those. If we're thinking about increased stress, and I think I could repeat this on virtually every slide if I were giving this talk last year, thinking about the experiences of it's just quantitatively different to be experiencing a pandemic and to be thinking about stress. We know that at the population level, we are experiencing a higher level of stress right now, living through a pandemic. And we could think about that at the individual level in terms of both chronic stressors and in terms of stressful life events that could be occurring within the household, loss of a job or financial strain. All of these can be particularly problematic for the developing fetus. What happens is during pregnancy, when the fetus is exposed to higher levels of stress, it causes problems with the hypothalamic pituitary adrenal gland, which really prompts this cascade of changes that can increase the risk of cardiovascular problems and metabolic disorders. So just like I was saying in the prior slide, this is what we've observed. And when we're talking about metabolic disorders, we're talking about diabetes. So it's really putting that individual, that fetus, at increased risk of problems over the life course. In the shorter term, and this is from building on work from Florencia as well as from Claire, we know that natural disasters or economic contractions from the Great Recession, for instance, that those can lead to overall preterm birth at the population level, higher rates of preterm birth and lower birth weight, which we also know are really red flags for problems over the life course. So increased stress can be particularly problematic. In terms of the second mechanism, we've identified undernutrition. Now, if we think about increased stress and we think about undernutrition, by and large, most people, and the data that we have is we use famines to try to understand what was happening or how in utero exposure to undernutrition can lead to problems over the life course. If someone is experiencing increased stress and undernutrition, they're likely experiencing those two together. So it's difficult to disentangle these two processes. On the other hand, using creative methods, there is evidence that if we use religious observations, so Ramadan involves a month of fasting. And so individuals who were in utero during the first month of Ramadan had a significantly lower birth weights. And we assume that Ramadan is not going to, have the same, be on par with the same level of stress for that pregnant individual. So net of this increased stress, we do know that undernutrition, and there are reasons to expect from animal models and other in other studies in biology that undernutrition can be particularly problematic during gestation. And then finally, this is perhaps where the mechanism that we would think of first during the 1918 pandemic, or even during the current pandemic. What happens when the pregnant individual becomes infected with the virus? Now, in prior pandemics, both the 1918 pandemic and then other pandemics, because there were a number of other pandemics that preceded the 1918 pandemic, they observed higher rates of stillbirth, higher rates of spontaneous abortions, which is another technical term for a miscarriage, and there were just higher rates of maternal mortality as well. In 2009, 2010, during the H1N1 pandemic, there were higher rates of complications for pregnant individuals, as well as higher rates of spontaneous abortion and stillbirth. And so this is something that we just tend to observe during these pandemics. In addition, we know that infection with viruses during pregnancy can be particularly problematic. It's one of the reasons why we try to encourage all pregnant individuals to be vaccinated during pregnancy. Cytomegalovirus can be particularly problematic. Rubella is problematic because it can lead to cataracts, and it can create a deafness as well as heart disease. And then it can alter the microbiome of the individual if they are infected in utero, and then early in infancy as well, leading to this hyperinflamed or hypersensitive state, which is problematic if we think about how that can affect them over their entire life course. So really, infection with viruses can be problematic. Now, one of the reasons why I have this set up here as a Venn diagram is because at the population level, not everybody's going to be experiencing undernutrition and infection, although I would mention that the majority of individuals who are living through the pandemic were experiencing stress. So there could be some who would fall in the middle of this Venn diagram who would be experiencing all three, but most likely, we're not going to have all of these individuals. And so we kind of have to think about these processes at the population level separately. I'm going to make one caveat here. I hope, and I'm very curious to hear your thoughts on this. One question that we've grappled with quite a bit and that others in the literature have thought about is, what about changes in ability to conceive, postponement, fertility, death of a partner, or financial stress? I mean, we know that people are changing their behaviors during the current pandemic. How did that affect what was occurring in 1918? So what I'd like you to do is just set that to the side, and we have thought about this and we address this in our analyses. But this is definitely something that we have been thinking about and concerned about in our analyses. So what do we expect could be happening here? If we think about what could be occurring in utero, if we make the assumption, and so here we're borrowing from Catalano, where he is talking about, we kind of make an assumption that for fetal survivability, there is a normal distribution. And there is a minimum threshold for survivability. Any fetus that falls below this minimum threshold for survivability would not survive and would die in utero through spontaneous abortion or some other physiological process, perhaps stillbirth. Now, what we could see occur in one of our hypotheses is that because of the pandemic, the threshold for this minimum threshold for survivability actually moves to the middle of the distribution. With this, you end up with a culled cohort. This means that a greater number of fetuses did not survive. They were spontaneously aborted, and what you end up with is a smaller cohort, but because that fetal survivability distribution does not change, they are on average healthier. So you end up with a culled cohort that is on average healthier in the first hypothesis. The second hypothesis that we put forward is that perhaps you end up with, again, that you start with the same distribution of fetal survivability with the same threshold here. And instead that threshold stays in the exact same place, but the entire distribution of fetal survivability shifts to the lower end. What this means is that a greater number of fetuses are going to be culled, but because we've had this shift, excuse me, I'm going to go back here. Because we've had this shift here, we see that a greater number of individuals are culled, And overall, that cohort is damaged and it's less healthy because the distribution is shifting to the lower end. So I'm going to put this, first I wanted to show you this in a figure, and then I'm going to give you more words than I usually would to spell this out. So for our first hypothesis, if that cohort was culled with little change in the distribution of fetal health, we will observe a negative relationship between exposure and child mortality among survivors. And this is simply because you end up with a smaller culled cohort that is on average healthier. On the other hand, with a damaged cohort, if the distribution of fetal health shifts to the left, resulting in a damaged cohort, with that threshold again remaining in the same place, we will observe a positive relationship between exposure and child mortality, because on average, you're going to end up with a smaller cohort if it is less healthy. So next I want to talk about our data, which we're quite excited about some of the data that we have available to use for this project. And so I'm going to start first by talking about child mortality, how we're measuring child mortality. So we start out with the US Census from 1820, which in some ways is fortuitous because it was just about a year and a half after the end of the 1918 pandemic. So we are able to measure where people are living and get a good sense of where they were in 1820. We then link children who were born between 1950 and 1920 with the US Census in 1930. Now, if you're not familiar, this is where our team at the University of Minnesota has been just fantastic and phenomenal in helping us ensure that we are having a high accuracy with our linking, and I'll go into that in our next slide here. But with this, we are making the assumption that if we're unable to link them, that those children have died in the interim. Now we're going to make some pretty stringent requirements in order to make some of these assumptions here. We exclude individuals if they are biologically unrelated to the household. If we're not able to link those parents, we exclude them from the analyses. And then also, as I'll describe, we need to have data on the city that they were born in order to understand whether the timing and whether they were exposed to influenza at a specific point in their trimester. So this leaves us with about 540,000 children at the start after we've done the linking here. In terms of our linking, just to kind of allay or kind of preempt some of your questions, our methods were correct in about 95% of our cases. This is something that my co-author, they've been really at the forefront of these linking efforts in terms of linking censuses at the Minnesota Population Center. And we have a relatively strict criteria by restricting to those that are biologically related. However, we do anticipate that there are some issues, and the most likely outcome is that there's some type of enumeration error and that individuals move to another household. So we do account for that. I'm going to talk about that in greater detail after I present some of our findings. And then finally, we did check to see if our child mortality rates matched the life tables by the Social Security Administration by sex, and they were very comparable, very close in terms of those child mortality rates. So next, we'll think about our data and our exposure. This is again where we have just a great team at the University of Minnesota who digitized the mortality statistics from 1910 to 1920. And what they did is they digitized all the cause-specific mortality rate by city by month for this time frame. And this is really, if we think about the data issues that we are currently having during our pandemic, to have city-level cause-specific mortality data from 1918 is really remarkable. From this, we identify individuals who died from influenza and pneumonia. And this is because during the 1918 pandemic, often people would get sick with influenza and then that would progress into pneumonia. And so we grouped those together. People who were dying of influenza and pneumonia were likely in that winter wave, at least in some way, exposed to the pandemic. From this, we created death rates, the monthly number of deaths due to influenza and pneumonia over our linearly interpolated population. Now here we're looking at this by 1,000. You're probably more used to seeing numbers by 100,000 right now. This just gives you a sense for how much higher mortality rates were in 1918 compared to today. So In terms of the way that the winter wave of the 1918 pandemic played out, again, there were waves that preceded this. There was a spring wave that occurred before this, and there were actually waves that occurred after June 1919. But we're focusing specifically on this winter wave. And so it's starting primarily in October of 1918, and it's going all the way through June 1919. And what I want to draw your attention to, we've selected 4 cities here with varying levels of intensity. We have Baltimore, Buffalo, St. Louis, and Indianapolis. And then what we're depicting here, these are, again, the previously described influenza and pneumonia mortality rates per 1,000. At the very bottom, what you'll note here is that we see these kind of dotted lines. These depict the monthly average influenza, pneumonia, and mortality rate. So on average, this is how many individuals would die of influenza and pneumonia, or how many died prior to the pandemic. And they're slightly higher for Baltimore and Buffalo on average, but I didn't want to, you can just kind of see in general where these averages are. So when these rates exceed the monthly average, that is when you're seeing this kind of excess influenza and pneumonia mortality, which is kind of the gold standard in terms of how we measure exposure to a pandemic or exposure to deaths at the local level. And so you can see what I really want to draw your attention to in this is this real variation in intensity. So again, if I were trying to describe this a year ago, I would have to explain how the pandemic arrived in one city and how it was experienced much differently in Baltimore versus Indianapolis. But we all know this, we have lived through this, we understand that the experience of the pandemic is just qualitatively different in New York versus in Madison here. And so you can see this really wide variation in intensity. And for the purposes of this presentation, just to kind of show you, we have divided these into high, medium, and low categories. Now, the other primary variable of interest is the timing of exposure. So we're not just looking to see whether the exposure to in utero infection has an effect on child mortality. We're really able to make these finer distinctions about intensity at the city level each month, and then also the timing of exposure. This is, again, the benefit of the data that we have. We're pretty excited about having access to these data. So if we're thinking about timing of exposure, the gestation is normally 40 weeks. And so we could imagine a fetus that was conceived prior to the pandemic in approximately September of 2018 would be exposed during the first trimester. If they lived in Baltimore, to this very high rate of mortality, and then in comparison, a significantly lower rate during the second trimester, and then much lower in the third trimester. And so we can see how there is going to be variation in both the intensity and then the timing for the individuals who are exposed in utero. So this is the same information. These are the cities that we have in our analyses. We have our high intensity cities, our medium intensity, and kind of our low intensity cities. And just here, this is kind of a snippet from one of our tables. We have the city, the start, the end, the duration, and then the peak monthly influenza mortality rate. So that from the prior page is really just the kind of the month with the highest level of mortality. And so we don't have, I don't have data on Wisconsin for many cities, but I do have Milwaukee, which at the peak had an influenza mortality rate of about 1.26 per 1,000. Now this compares to Philadelphia, which was one of the cities that was hit hardest at the very start of the pandemic. And they experienced a mortality rate for influenza and pneumonia of about 5.75 per 1,000. I did do just a little bit of background research, and I was discussing this with a couple of people yesterday that Madison had a very similarly low mortality rate, and this is because they had a really great public health system, and they engaged in these non-pharmaceutical interventions right at the start, and this resulted in a much lower mortality rate at Madison. Okay. This is just a table to kind of show you who was exposed and when they were exposed. The percent born in the first quarter, this is again kind of the gold standard for what people have done. If we're looking at exposure, we're able to get at this for each month. So you can see how many were exposed overall, and how many were exposed by month. And so this is again depicting about that winter wave from October 1918 to, and here we're going into even November 1918, and then the percent exposed in each trimester, trimester 1, 2, and 3. So we end up with about 510,000 cases. So in terms of our analytical approach, we fit within pair sibling fixed effects model. And for ease of interpretation, we use a linear specification with an ordinary least squares estimator. Our results were substantively the same when we used a loaded estimator. And to be clear, we're modeling the risk of dying among individual I and sibling pair J in that 10-year interval. Now, and this is comparing individual I who is exposed in utero compared to their sibling who was not exposed in utero. So when we are looking at this particular model, we are focusing on intensity of the exposure, high, medium, and low, the timing of the exposure, the first, second, and third trimester, as well as the interaction between the two. Now, in this particular model, we have unobserved contextual characteristics and genetic endowments, respectively. So one of the benefits of using a sibling fixed effects model is that you're able to account for or control for some of these unobserved characteristics. So the family level characteristics or neighborhood characteristics. And then another benefit is that you're able to account for some of these genetic endowments, because siblings on average share about 50% of the same genes, much like you would have a dizygotic twin pair. And so this is one of the benefits of using a sibling fixed effects model. I do want to mention that our models also control for sex, of birth cohort, and city of birth. So in terms of finding initial evidence of culling, what we did is we took the birth data, and this is using the 1920 census, and we're able to ascertain birth dates. We show the aggregated months of birth over time from, again, so I want to just kind of orient you to this graph here. This is meaning May of 1915, and this one here is January of 1916, January of 1917, January of 1918, and January of 1919. And so this is what the x-axis is showing here. The y-axis reflects the relative size of the actual monthly birth cohort compared to what seasonality trends suggest that it should have been. So you can see that there is just natural variation in what we would expect for births. And then right around November, December of 1918, and then June 1919, we see this decline in births. So this has been observed elsewhere, both in the medical literature, in the economics literature, and demography literature, that these are kind of termed a birth trough, something where the births are declining significantly. And so we do find evidence of culling in both of these periods, but in particular, this June period right here, this is corresponding to individuals, again, that were conceived right around September 2018. And so we're going to see this kind of decline here, or later. So again, just to orient you and return to our hypotheses, if the cohort was culled with little change in that distribution, and we just end up with this, the thresholds moving to the middle of the distribution, we're going to observe a negative relationship. On the other hand, if the entire distribution shifts to the lower end, we're going to have a damaged cohort, and we're going to be more likely to observe child mortality among that cohort. So what do we find? So I'm going to walk you through some of our findings here, and just to orient you here, when we're looking at this, we are, our models, the coefficient represents the difference in risk of dying between siblings who were exposed and unexposed. And so first, just to show you, if an individual was exposed in utero, they had about a 1% lower risk of dying. Now, this is non-trivial considering that the mean probability of death was about 5% over this time period. So this represents about a 20% reduction. Now, if we look, again, this kind of a standard approach is for those who were born in that first quarter in 1919, they were exposed in utero. We see the effect increases just slightly, but 1.2% lower risk of dying in the interim. Next, we look at when or whether people were exposed or fetuses were exposed to a low intensity, a medium intensity, or high intensity city. And we see that regardless of intensity, they had a lower probability of dying in that interim. And then finally, and what I want to be really kind of the take-home message here is that across all of these models, we see this negative association, that individuals who were exposed in utero were less likely to die in that 10-year period after. But what I want to particularly point out is that we do observe differences by timing of exposure, such that individuals who were exposed in the 3rd trimester were not less likely to die in the 10-year period after. And this really aligns with research that we have on natural disasters and on economic contractions, that it's that exposure during that 1st and 2nd trimester that is particularly damaging, particularly problematic. And so here, by distinguishing between intensity and timing, we're able to differentiate when during gestation and when during that prenatal period, it's particularly problematic for the developing fetus. So next we interact the two, and when we interact the two, again, we see for all levels of intensity the same negative association that people have, that fetuses had a lower risk of dying in that 10-year interim compared to their sibling that was not exposed in utero, except for those that were exposed during that 3rd trimester. So it could be that those individuals, the fetuses were far enough along in the pregnancy that being exposed to stress, undernutrition, and infection did not, cause problems, and they were not culled to the same extent as those that were in the 1st or 2nd trimester. So we, as a team, we have gone around and around and thought about many explanations and many potential issues that could have arisen. And so I'm going to walk you through some additional sensitivity analyses that we've conducted. So when we're using the census data, we need to think about when individuals were born. We have to make some assumptions. Were they born on the 1st day of the month or the last day of the month? We assumed that they were born on the last day of the month rather. When we changed this to the 1st day of the month, it did not change our results. They were consistent. One of the questions that is a really important question to ask is, we're looking at cause-specific mortality, but perhaps all-cause mortality would be a better measure, because as we've seen during the current pandemic, we know that people are not only dying from the coronavirus, but they're also dying because they're not able to get the care that they need, or it's exacerbating other health problems. The stress perhaps is exacerbating other health problems. And so we're observing this excess mortality in general. So perhaps that's a better measure. So we conducted the same analyses using all-cause mortality, and our results were the same. We also wanted to understand, well, perhaps if we loosen some of our restrictions on our linking, if we did not restrict to parents who were linked across censuses, that could change our analysis. This was not the case. One of the issues when you are looking at census data is that there can be age heaping, in that when people are reporting the birth dates of their children, they're more likely to say that those kids were born in, that they're exactly 4 years old, or that they're 4.5 years old, so 4 years and 6 months. And so if you have those age heaping at month 0 and month 6, that can kind of distort your results, especially because we're concerned about specific timing. And so we looked at this excluding and then including those individuals that were age heap, and it did not change our results. One of the other concerns is that individuals may have been born in a city but then lived in a different location in 1920s, so perhaps their place of exposure differed. So we're concerned about this kind of migration occurring early in life. And in fact, when we restrict to those whose birth and residence were identical, we found similar results. Some of these processes can differ by sex, and so after we restricted this to boys, our results were substantively the same. And then this line here is returning to that question of changes in fertility behavior, in the ability to conceive, in loss of a partner, financial strain, all of those social and behavioral changes that we expect during a pandemic. So we were thinking, how can we understand this? How can we creatively test this? What we did is we created a separate measure for individuals that were conceived prior to the start of the pandemic occurring in their city. So here we were able to get a much finer measure of when the pandemic arrived in, for instance, Indianapolis. And we were able to say, well, if the pandemic arrived just a little bit later in Indianapolis, we can say these fetuses were conceived prior using normal gestation of 40 months. We know when the fetus was conceived. We know that we're going to kind of separate these two, and we're going to say these fetuses were conceived prior to the pandemic and before we would expect these behavioral changes, because people were not anticipating changes in fertility behavior right before the pandemic was occurring in their city. And then, and our results were the same for both of those measures. Finally, one concern that we had with the sibling fixed effects model is that we could be capturing issues related to birth order or something that's specific with those siblings, and that could be biasing our results. And so we took the 1917 and 1918 period and used that as a comparison to this 1918 and 1919 period, and conducted the same analyses to see without the pandemic occurring, are we picking up some differences according to birth order for those siblings? And in fact, using that falsification test where we do not have where a pandemic was not occurring, but we do have that same birth order among those siblings, we did not see a difference in our analyses. So returning to our hypotheses here, again, we have our two hypotheses, one anticipating that we're going to have a negative relationship, and the other that we're going to have a positive relationship. Now, what we do find evidence of this culled cohort that we have, kind of assuming this normal distribution of fetal survivability with a minimum threshold of survivability. We found evidence in support of this idea that that minimum threshold for survivability is moving to the middle of the distribution, and that we are indeed observing a culled cohort that is on average healthier and less likely to die during childhood. Okay, so the big question, can we apply these findings to the current pandemic? This is something, I have found myself speaking to a number of different people and to journalists, and, what can we apply from this work? And all of us, especially the epidemiologists on the team, are saying we would want to be very careful. In spite of the fact that there are so many comparisons between the 1918 pandemic and the current pandemic, there are so many differences in terms of the availability of contraceptives and the spread of medical knowledge and medical technology, and even the impact of the pandemic at the city level. So we would need to think very carefully. I would say that there are so many similarities in terms of these experiences of stress, of chronic stress at the individual level, not just for pregnant individuals, but for everybody experiencing the pandemic. Undernutrition, we know that food security is an issue right now, and then that infection is a real issue right now for a significant portion of the population, particularly those areas that have been very hard hit, like New York, Florida, or Arizona. One piece of information that we can look at, most recently, there is evidence, as with prior pandemics, that individuals who are pregnant have a higher rate of complications. They are more likely to have a spontaneous abortion, stillbirth, or just other problems during pregnancy. And this is a piece from the New York Times in the middle of the summer that was really trying to understand, during the coronavirus lockdown, a number of obstetricians and gynecologists were noticing that there were not as many preemies. And so this is, again, potentially evidence that we are having, that during the pandemic, there has been another kind of cohort that has been culled, and that infants that now during 2020 would normally be preemies, and they would be able to go into a newborn intensive care unit, for instance, or a neonatal intensive care unit. They're no longer they're no longer surviving to birth, and so we're ending up with a cold cohort. And so this is something that we would want to study empirically to understand. But again, the signs are pointing in that same direction, that we are experiencing similar processes during the COVID pandemic, as were experienced during the 1918 pandemic, net of the differences that we have observed. So next steps, where can we take this going forward, and what does this mean in terms of our research on the 1918 pandemic? So returning to the kind of the life course perspective, and thinking that we need to really build and understand what's happening, not just during these critical periods and these sensitive periods, early childhood, but saying, well, what's happening during gestation? And then I would argue it's important to understand even what's happening during this preconception period. So if we think about the influenza pandemic, there's a great deal of research that suggests that it has a number of deleterious health effects as people age, and as people as we try to understand their overall life expectancy and their experiences over their life course. And our study really fits this kind of missing piece of the puzzle. We find lower rates of child mortality for individuals who are exposed in the first and second trimester compared to their siblings that were not exposed in utero. So how do we fit these two pieces together? This is, again, something that our team has been thinking about. I welcome your comments and questions on this. One of the kind of key points that we were thinking about is that perhaps the cohort is culled, but that there is some type of latent effect that we're not observing until much later in adulthood, that these individuals are surviving childhood, but then something manifests much later in the life course, where you don't really see it until they're aging around 50 years of age, for instance, or older. So this is just one kind of hypothesis in how we fit these two pieces together. But I would welcome your thoughts and your input on this in particular. So returning to kind of life course theory and kind of thinking about where this fits in with a broader picture and where we can go from here. With these data, we actually have information on race at the city level by month. And so this is something that, I've just started talking about a project actually with a co-author, with my wonderful co-author at the University of Minnesota with Jonas Helgerts, with the co-author at Penn, Courtney Bowen, and then with one of your alumni, Elizabeth Wrigleyfield, trying to understand how some of these exposures differ by race at the city level and what's happening. So we kind of understand this basic physiological process, but then what kind of inequities do we see by race? And then how do those inequities set people on this kind of life course trajectory? And I just think that this is an excellent area, and we're pretty excited that we have the data at the city level by race to start exploring this. So with that, I think I'm just about on time. I welcome your questions and your comments, and I think, let's see, I will stop sharing my screen. There we go.
Thanks, Elaine. Let's try the chat function for our question queue. That might make it easier. As we were thinking about your questions, I'll maybe raise a really straightforward, simple one as we're thinking is, when you go back and think about your results and your use of sibling differences, now that you've done the research, was it pretty consequential to use sibling differences versus maybe what you would have found if you just didn't have access to these really nice data that allow you to use siblings?
No, and we started out not using siblings, in fact, and our results were pretty similar to what we'd expect. In fact, we kind of started out linearly, just kind of thinking through those very methodically, and then moving on to siblings because we have the data that we have.
Is there consequences of using siblings that make you want to keep that? Because you must be losing sample because you have to have siblings in order to be in the sample or something, and all the linkages that you have to do.
That is true, and I think that we could separate that according to non-siblings. Um, I think that's a question that we could definitely explore in greater detail to see if there's a difference between those sibling pairs and those non-sibling pairs. I think that's a good suggestion.
One other thing that might elicit other questions is your hypotheses about, get the language right, it's culling versus damage. Is it fair to interpret your analysis as the net effect of those two processes, rather than like ruling one in and one out, that they both could be happening and you're getting the fact that one of them might be overwhelming the other process? And if that's, and you're shaking your head, sounds like you agree. I'm wondering if there's any next steps that would try to sort that out, or is that just not going to, is that just really hard to do with the data you have?
Um, I think that's a really excellent point, and I think that that's happening. I think that one kind of finer distinction that you could make is that it could be for individuals that have some ability to buffer these stressors, that you have some of these processes. So when we're looking at this at the population level, you're not able to account for that. I think for this set of analysis, because we have so many things happening, I don't know that we would try to have a finer distinction on this, but I definitely think in future analysis, I think that would be a really excellent question to try to understand. The biggest distinction that we've observed in this analysis and then in other analyses is that it's that third trimester. So, just setting this aside, just, I don't know, between us, we did find that for that third trimester, there was a positive association for some of our analysis in prior models that we had run, which would indicate that for those in the third trimester, they are more of a damaged cohort. So they're able to survive better because the fetus is larger, but they're experiencing a greater amount of damage. And then they had actually a positive association with child mortality. This is not, once we did our final specifications on our model, that's not what we found, and we're being more conservative in these final models. But in some of our analyses, we did find that.
Thanks. Does that generate other questions from the group?
Let's see. You're making it easy on me, everybody.
If not, maybe you could spend 2 or 3 more minutes on either. I guess I'd either invite you to talk about other opportunities with the data that could or may not be related to the influenza pandemic, or in some sense going back to your future steps where you have a lot of other data like race of the households and so on, and like what's some of the coming attractions on your own project.
Right. So we've thought kind of carefully about how we could look at cities versus states. Is there a way to make a distinction between rural areas and urban areas? Because in fact, we have differences by race and rural versus urban status. And this is something, I mean, just more generally, that a lot of my work takes me in the area of health inequities. And so we know that during the current pandemic, we just have these significant racial inequities. And so I think we really want to understand what's happening by race at the city level. If we look at all-cause mortality versus cause-specific mortality, I think that we need to start out, because most of what we know is based on annual data. And this is where Elizabeth and I have been speaking, and once we're able to talk about some of the data that we have available and the kind of ideas that we've been talking, we've been really excited to take these first steps. I think that the first thing that we need to do is we just need to get a really, really clear explanation about what's happening descriptively. And I think that each level of that is really important. So it's by race, rural, urban status, and then cause-specific versus all-cause mortality, because I think that all-cause mortality, especially from what we're seeing now, is really important to consider. And then from there, I think that's where we can build on this. I think that if we envision that these exposures are different for different races, then, I mean, this opens all kinds of questions, and even some of your work, Jason, on the intergenerational transmission of some of these inequities over the life course in the United States. And so first, my objective is to try to make sure that we get a really solid foundation of understanding and then kind of build from that to understand these broader trajectories.
Thanks. Ava, could you unmute yourself and ask your question?
Yes, hi. Can you hear me all right?
Yes.
Okay. Hopefully it won't cut out. So I do have a question about the data reliability. I'm working on a similar project, but it's not with the 1918 epidemic. And I'm just wondering, especially if you're going to be including race, how will you be evaluating the data quality, and how can you reliably say that the variations that you observe in the mortality statistics are real ones and not because of just data collection and biases related to that? I'm wondering in terms of, do you know what the magnitude of the error is due to data collection versus the magnitude of the differences that you see that are real?
I think that's an excellent question, Eva. And I think that when we're talking about race, it's going to be particularly concerning. I think that to a certain extent, we're at the mercy of the mortality statistics, which, although they are fantastic and impressive given the time frame, they're imperfect. And I think that making comparisons to historical records is going to be one start. I think that looking at the mortality data that are published, and this, again, most of this is published annually. So I think that looking at specific cities is one way to get at this issue. What occurred in Philadelphia, and this is actually what we've talked about for our analyses, is that we have this broader picture, but then let's dive into one specific city or another specific city to really try to understand, well, what happened in Madison and what happened in New York, and how did that differ? Because I think that having that kind of foundation for what we want to understand is good, but then kind of build off of this and tell a little bit more of a narrative. And so then I think that our best, or our first step at least, what I would want to understand is look to historical data. That's a good.
So I guess, yeah, as a follow-up to that, my question is, just to clarify, are you saying that, you know, if we're just looking at Madison, we're expecting the same bias in Madison over this short period of time, and therefore, you know, looking within cities is going to give us, even though the data may be inaccurate, at least they're consistently inaccurate in the same way? No?
I don't know that we could make that assumption. I think that
Okay.
that we're going to have, just like we have right now. I mean, I think that the data, this is one of the benefits and one of the reasons why it's good that we have more than one city, and it's good that we have a number of cities. But you are exactly right that there's going to be a lot of problems with the data, just like we're experiencing today. And so I think that that being said, I do think that it's really important to tell this story and to look at these differences by race from 1918, especially given what's happening right now. That's really kind of at the top of my list of wanting to understand, you know, kind of a post-pandemic new project, what are the differences by race? Because even if we don't have the best data, it's still such an important subject to talk about those inequities.
Mihal, can you unmute and ask your question?
Sure. Hi there.
Hi. Yes.
Thank you for this talk. I was thinking a lot as you were presenting that this is a really nice empirical example of some of the theoretical ideas that people like Jim Vopel wrote about in terms of frailty and heterogeneity in populations, right? So it's basically this idea, right, that processes that are unobservable that are happening in utero are resulting in the birth of a cohort that has a distribution of vulnerability to mortality that's different than a cohort who might not have experienced that at birth. And so I was wondering, so one of the things that came out of the early work, right, that was being done on this in the 70s and 80s in terms of thinking about the theory of frailty and how heterogeneity would play out empirically, is that it's sort of a little hard to know what to expect from frailty, right? Because on the one hand, you've got these changes in the underlying sort of robustness or frailty of the cohort. Then this cohort is also growing through a time period when life expectancy is improving for everyone, right? And at the same time, other things are changing in terms of broader social inequalities, maybe health behaviors as well, that are also resulting in sort of poorer health outcomes in later life, as you said. And so I'm wondering if you could talk a little bit more about how sort of the theories of frailty would inform what you expect to be, like the clarity with which you might be able to sort of posit, right, the hypotheses about what you should expect, and also how you think that might play out once you start thinking about other levels of heterogeneity, right, racial disparities on top of all of that, and what would you expect to see given the differences in sort of maybe selections of cohorts that were differentially exposed to the flu pandemic, but then also subsequently differentially exposed to the force of mortality from a variety of other things throughout the life course later.
I think I think I'm going to hand the talk over to you now. That's a great question. I mean, I think that you're asking a lot of really important questions. I think that the demographer in me would point to the age structure and how that, and this is one of the first questions that we've asked in terms of race, is how is this going to differ for whites versus blacks if we're looking at mortality. And I think that we could say the same for the rural population versus the urban population. That would be one of the first places that I would want to understand, what's happening at the population level, just to get a sense for the heterogeneity across the United States. And I think that that's where we need to really get a sense. So I wouldn't be able to make a specific prediction, but I would take from that, there's some evidence that actually people of color, that blacks were experiencing lower rates of mortality. And so there's some kind of question about, is there something, did they experience higher rates of mortality that in selection up until the point of the 1918 pandemic? There's also questions about exposure among people in rural areas versus urban areas. And so, I mean, I wouldn't be able to make specific predictions without really being able to, we haven't had a chance to dive into the data. But the first thing that I would want to understand is that underlying age structure of these different populations in the rural area and the urban area, because I think that's really going to kind of help you understand the experience of the pandemic, because it was a little bit different in terms of how it's struck and how you have I didn't talk about this as much in the talk, but I'm not sure if you're familiar with, it really struck the individuals in the middle of the age distribution differently than we're looking at here in the kind of current COVID pandemic. And so that would be one of the first clues to how we're having these differential experiences by city. And then that is one of the best clues to how you understand what's happening in utero, is this kind of excess and this all-cause mortality. That's going to tell you a little bit more. You're going to really want to have a good sense then also of how many women of childbearing age were in an area. And this is something that we've kind of struggled with, how to kind of understand this and how to measure who's at risk within specific areas. But it's one of the reasons why we're excited about the data, is because we're actually able to look at that at the city level over time. So, I mean, I don't have a more clear answer, but I think that the questions that you are asking are exactly spot on, and that those are the types of questions as we're moving forward that we're going to want to think about.
Yeah, it seems just, it might be interesting to think as you move along with this work, that one of the tricky things about, working with this idea of frailty and of differential selection and how it will play out is that rather than sort of like a straight thing, like you were exposed to something bad and that means that later things are bad or later things are good, there's a lot of interplay of things like failures of success or the later success of failure, right? So failure of success being, you know, people are living longer, but then population health is worse because people are, you know, more of the sicker people are surviving. And the opposite of it, like the success of failure, is what you're describing in terms of like the culling of the frailest people in the population, and then they continue longer. And so I think that would create really confusing, right, and interesting dynamics to disentangle in terms of how you should pose hypotheses and expectations for what you might be able to see in these patterns, and also make it really hard to know whether what you're seeing in the data, right, like how did that play out? There's a lot of unobservables that will be really interesting to think about. So
you are hitting on a lot of the conversations that our team has had over the past year, and really just trying to disentangle what are we testing. I mean, and you can see this is one of the reasons why we've gone methodically through the data to try to see, well, what in this instance could this be happening? Could we be observing? Could we be biased from X, Y, and Z? And so most definitely we've gone through a lot of these discussions and a lot of these conversations. And so this is I think those are really important kind of first questions, especially as we move forward. I will say that this is taking it in a little bit of a different kind of direction, but so I'm a medical sociologist, and I teach and I talk to people about the kind of epidemiological transition from infectious to chronic diseases, and how in the beginning of the 20th century, most likely people were dying from infectious diseases. At the end of the 20th century, it was chronic diseases. And now we have the pandemic, and something that we taught and something that we don't really think about, we think about more in the abstract, is actually occurring. What I think that we're going to find over time is that these chronic diseases actually have an etiology in infectious diseases, that they were prompted by infectious diseases earlier in the life course, or that cancers actually were caused in a lot of cases by exposure to either viral infection or some other bacterial infection or something. And so we're going to find that what we really thought about as an epidemiological transition in the way that people are experiencing disease and illness over the life course is actually kind of rooted in a different cause. And I think that that's a really interesting concept to kind of think about over the life course, especially as you're talking about is this kind of mortality compression that we're experiencing right now in the 21st century among very highly educated individuals in particular. So
I'll be really interested to see what you find. I think, you know, about maybe 15 years or so, Eileen Crimmins and Tuck Finch at USC were really interested in this idea, right, that cohort patterns of mortality are reflective of their experiences with infectious disease in early life, maybe through processes of inflammation. And it's interesting because I feel like there was a flurry of research around that in the sort of like late 2010s, and it kind of petered out, I think, you know, maybe for lack of findings along that way, but it'll be interesting to see what you find.
Yes, well, it's all on my shoulders now, huh? Thank you so much. I appreciate your questions and your comments. Those are great.
And thanks again for Elaine. I know that Ava and Gracie are going to hang around to continue your conversations. Other students, you can hang around too, but for everyone else, I think it's time to sign off and thank Elaine. Good to see you again, Elaine.
Thanks. Yes, great to be here. Thanks for having me.